invite again, and you may proceed
Sure,
with your presentation.
sure, ma'am. Yeah, thank you for inviting me to give this talk. Appreciate it. Well, good morning, good evening, everyone. Again, as Dr. Kavita Madam already mentioned, my name is Anil Dasyam. I was a NIMS resident back in 2000 to 2003, early 2003, currently working at Pittsburgh. I'm going to be talking about imaging of cystic pancreatic lesions. A lot of you already had a session from KJ sir yesterday and today, I guess. So I don't think I'll be adding much more, but just let's go through this journey. Okay. I do not have any disclosures. In this talk, I'll be talking about classification of the pancreatic cystic lesions, how we investigate these lesions, and we will go through some common pancreatic cystic lesions, common or clinically relevant pancreatic cystic lesions. We'll look at their imaging manifestations. And then finally, briefly, we'll look at some guidelines as to how these pancreatic cystic lesions are managed. So pancreatic cystic lesions are very common. If you look at older literature, the incidence was quoted as less than 1%. But with increasing utilization of imaging, we definitely see a lot more pancreatic cystic lesions. So if you look at any of the studies that are more recent, especially if they have included older subjects, and if they have included MRI as a predominant imaging modality to detect cystic lesions, you'll notice that the pancreatic cystic lesion incidence has gone way up, with some of these quoting an incidence of more than 40%. So we do see these practically every day in our life. What is the clinical significance, and how do we manage these things? So pancreatic cystic lesions are broadly of three types. Ones that are malignant, so you already have a malignant component in these patients. So in these patients, if they are unresectable, the prognosis is dismal. And even for those that are resectable, if it's an adenocarcinoma, despite surgery, the prognosis is not that great when you compare with other malignancies. So in these patients, it's important to recognize early that there is a malignancy and to offer curative surgical resection if that is possible. On the other end of the spectrum, we have benign cystic lesions. These are way more common than other lesions. And in these lesions, it's really important to identify that it is benign and that it doesn't have any malignant potential. That way, you avoid unnecessary follow-up, anxiety associated with whether this is a malignancy or not, the expense related to any follow-up, and you also avoid unnecessary surgeries because pancreatic surgeries are major surgeries that can be associated with significant morbidity and to some extent, sometimes mortality too. And there is a large group of cystic lesions that are in between these two. They are either pre-malignant or potentially pre-malignant. And these cystic lesions, you want to make sure that they undergo surveillance to detect malignancy if it does develop, or you offer surgery if it is appropriate for a subgroup of patients. So how do we know where to place a cystic lesion? It's not that easy. And we need to understand what kind of cystic lesions can occur in the pancreas. So broadly, these pancreatic cystic lesions are classified as true cysts, that is, they have an epithelial lining to them, or pseudocysts, which is they don't have any epithelial lining to them. Again, these are subdivided into neoplastic and non-neoplastic lesions. So you can see that this whole slide is filled with numerous entities. A lot of these, fortunately, are not common, and we don't have to know all of those lesions. So we'll just try to simplify it a little bit further. So on one end, we have non-neoplastic cystic lesions, such as pseudocyst and some other congenital cysts. And then we have, on the other end, cystic degeneration of malignant solid lesions. So this is either a pancreatic adenocarcinoma that has a cystic component or some other malignancy that has a cystic component. And then you have some neoplastic cystic lesions, which are either benign or they are malignant or they have malignant potential. These include serous cystadenoma, IPMN, MCN, and the solid pseudopapillary neoplasm. When you look at the incidence of these cystic lesions, the vast majority of the lesions that we see are just a few of these cystic lesions. Pseudocysts and IPMNs are extremely common, accounting for more than 50%. And then you have the serous cysternoma, MCN, and solid pseudopapillary neoplasm. Together, based on which study you look at, they constitute at least 80%, or, according to some studies, up to 90% of all the cystic lesions. And since we are utilizing imaging a lot more than before, and we are detecting a lot more IPMNs more than before, I think these statistics will change, and we'll have a lot more IPMNs that we'll be seeing in future. So once we have detected these lesions, what do we do next? So you want to investigate further if necessary, and try to diagnose, characterize as to what this cystic lesion is, and then appropriately manage it. So how do we characterize these lesions further? First, we try to look at the demographics. The first thing is you look at the gender. A lot of the pancreatic cystic lesions do not have much gender predilections, but there are some that do. Lymphoepithelial cyst is one of the cystic lesions that's way more common in men than in women. But there are a few cystic lesions that we see way more commonly than lymphoepithelial cyst that are much more common in women. So you have serous cysternoma, which is 4 times more common in women, and you have solid pseudopapillary neoplasm and mucinous cystic neoplasm, which are almost exclusively seen in women. So way more likely to be present in women than in men. So you don't want to make such a diagnosis in a man. Next, we look at the age. Some of these cystic lesions do not have any age predilection, such as pseudocyst, that can occur at any age, while there are some that are staggered in different age groups. For example, the solid pseudopapillary neoplasm is seen in the younger age group, mucinous cystic neoplasm, or MCN, is in the middle age group, and then you have the serous cysternoma and IPMNs, which are usually in the older age group. So when you combine these two, there are a few entities that are more likely to be recognized early and confidently. These include the solid pseudopapillary neoplasm, which is seen in younger age group and in women. So typically it's called as a daughter cystic lesion. And then you have the mucinous cystic neoplasm, which is seen in the middle-aged group and in almost exclusively in women. So it's called as a mother cystic lesion. And then you have the serous cysternoma, which is seen in older age group and also more commonly in women. So it's called as a grandmother lesion. Next, we look at the clinical presentation. Now, in patients who do have pseudocysts, it's very useful to get this information that they have a known history of acute pancreatitis or chronic pancreatitis, or sometimes they present with clinical features that suggest that they have one of these two. So in pseudocysts, it's very important. But for a lot of other cystic lesions, the clinical presentation may not be very helpful. They are either asymptomatic or have some of these vague symptomatology, abdominal pain, discomfort. Occasionally, you'll have somebody who has jaundice with a more aggressive lesion, or the location is located in the head and causing a lot of mass effect. And then you have some of the cystic neuroendocrine tumors that may have hormonal secretion and cause some symptomatology. But again, that's very uncommon too. So we rely a lot on imaging to make a diagnosis because the clinical features are not so helpful. Among the different imaging modalities, the most commonly used imaging modality worldwide probably is CT scan. It's excellent at detecting these lesions, characterizing, making a diagnosis as to what kind of lesion this is. It's also great to identify aggressive features such as enhancing mural nodules, thick septations, or a thick wall. And it is the best imaging modality to identify presence of any calcifications in these cystic lesions. And when you do have a malignancy associated with the cystic lesion, this is the best imaging modality currently to stage the malignancy. But of course, CT does have some of its own downsides. It's not great at detecting tiny cystic lesions. It's not great at identifying the ductal features, and it's associated with ionizing radiation. So when somebody needs long-term follow-up, multiple exams or several years, this is not the imaging modality that you're looking at. Next, we have MRI. This is, again, an excellent imaging modality that's probably the best for detecting pancreatic cystic lesions, and also great at identifying and characterizing any kind of ductal features, whether there is involvement of the duct, there is any internal complexity within the duct, etc. It's also great at identifying aggressive features within these cystic lesions. And it's actually better than CT scan in characterizing a cystic lesion as a particular, arriving at a particular diagnosis. You're more likely to do that with MRI than with CT scan. Another big advantage is that there's no ionizing radiation. So somebody who needs multiple follow-ups or several years, this would be the imaging modality of choice. Of course, MRI also has its own downsides. It's not great at detecting calcifications. It's very motion sensitive, so you're more likely to have some kind of a motion degraded exam that is not interpretable with MRI than with CT scan. And another problem is it's expensive. Coming to ultrasound, transabdominal ultrasound is great when you do have good visibility. It's great at characterizing the internal architecture of the cystic lesion, probably even better than CT scan in some instances. However, at least for our set of population, we see that we cannot see the entire pancreas in a lot of patients. A lot of times it's obscured by overlying bowel gas, or because of their body habitus, you don't get to see it very well. So abdominal ultrasound is not used frequently as a primary imaging modality to identify lesions or characterize them. We do use endoscopic ultrasound though. It's very commonly used and it's extremely useful. You have the ultrasound probe directly over the pancreas, so you can have these high resolution images. It lets you see the internal complexity, sometimes much better than what is definitely better than CT scan, and sometimes better than what we see on MR. It also gives you this added opportunity to sample the lesion. You can either get an FNA of any solid component or aspirate the cyst fluid for further analysis. The downsides, it's a little bit invasive, it's operator dependent, and when you have large cystic lesions, you have high resolution imaging giving you great images, but the resolution is rapidly lost at increasing depths, so you can't see the entirety of the lesion. So next thing that we do is cyst fluid analysis. When you can make a diagnosis and you think it is benign, then that's good. Based on the other imaging modalities, that's where you would stop. But where you think that this has malignant potential or there are some concerning features, and you're not sure of the diagnosis, then we go for cyst fluid analysis, which is typically through endoscopic ultrasound, sometimes percutaneous. Stick a needle in, get FNA, trying to look for cytology or look for other constituents of the fluid. Cytology is amazing. When you do have enough tissue to make a diagnosis, you can fairly confidently make the diagnosis of a malignancy or characterize it as one lesion versus other. But unfortunately, the adequacy of this specimen is pretty low for these predominantly cystic lesions. Less than 1/3 of them actually have enough tissue to make a diagnosis. So that is the reason we rely on so many other fluid markers. Some of the common ones that we use are CEA. A higher CEA indicates that it's more likely to be a mucinous cystic lesion. 192 was taken as the cutoff in one of the studies from our institute, and that's pretty widely followed everywhere. But there are other studies that show different kinds of cutoffs. But essentially, a higher CEA indicates that a cystic lesion is more likely to be mucinous than non-mucinous. Next is glucose. This is a more recent advancement. Mucinous lesions again tend to have low glucose, while non-mucinous lesions typically tend to have glucose levels above 50. This has been very useful. Some of the recent studies claim that this is more sensitive, more accurate than CEA in characterizing lesions as mucinous versus non-mucinous. A big advantage is that you don't need a lot of fluid for estimating the glucose level. Even a few drops are enough. Next is amylase, something that we don't use much. If you have low amylase, you can very confidently exclude pseudocyst as a possibility. But for most other lesions, it's not great at characterizing these cystic lesions. And then finally, we have molecular markers. These have been extremely useful in our institutional experience. And we see several other institutes sending their sample to our institute because we have been doing a lot of these. Molecular markers, we are talking about either RNA-based or DNA-based molecular markers. We do a lot of DNA-based markers. These are very helpful in establishing the diagnosis in a lot of cystic lesions. For example, KRAS mutation is seen in mucinous lesions. That is, both MCN and IPMN can have KRAS. GNAS is a mutation that is seen in IPMN, but not in KRAS. VHL mutation is seen with serous hysteroblastoma. CTNNB1 mutation, in absence of other mutations, strongly indicates solid pseudopapillary neoplasm. A MEN1 mutation indicates NET. In addition to helping with diagnosis, it also helps with identifying high-risk cysts, that is, those cysts that harbor either high-grade dysplasia or invasive cancer. When you see mutations like SMAD4, TP53, some mutations along the mTOR pathway or CTNNB1, these indicate presence of a high-risk lesion. So these are all the different things that we try to glean from the cyst fluid. Now let's look at some of the common or clinically relevant pancreatic cystic lesions. So I'm going to be briefly going through solid pseudopapillary neoplasm, mucinous cystic neoplasm, serous cystadenoma, intraductal papillary mucinous neoplasms, that's IPMN, cystic neuroendocrine tumor, and finally, briefly, we look at pseudocyst. First, let's start with solid pseudopapillary neoplasm. Now, this is a cystic lesion that is commonly seen in the daughter age group. So we are talking about late teens, 20s, early 30s. That's a typical age group, women, and that's why we call this as a daughter cystic lesion. The clinical presentation is very variable. Some present with abdominal pain, distension. A lot of these are without any symptomatology. Rarely you'll have somebody who has a palpable mass, nausea, weight loss, etc. These are almost exclusively seen in women. I saw one case in a late teen. He was a male patient. Interestingly, he had mosaicism with XX and XY. These have malignant potential, but usually have excellent prognosis. After resection, the survival is nearly 97% at 5 years. When coming to the imaging features, these can be located anywhere within the pancreas. They're typically large with an average size of around 9 centimeters. It's a mixed solid cystic lesion typically, so you tend to see some solid components that usually have minimal enhancement, and you may see cystic components that are either hemorrhagic or non-hemorrhagic. So you see a lot of T2 hyperintense and T1 hypointense, T2 hypointense components, but also because of the hemorrhagic components, you tend to see T1 hyperintense components very frequently in these. It has a thick fibrous capsule, so it's common to see a T2 hypointense capsule around the cystic lesion. And despite its large size, often it does not result in any obstruction of either the pancreatic duct or the bile duct. Almost always you get a diagnosis based on cytology in these patients because they often tend to have decent amount of solid components, but sometimes you don't, and they have predominantly cystic components, in which case the mutation that we look for is the CTNNB1. In absence of KRAS, GNAS, or other mutations, if you see this, that's pretty strongly suggestive of SPN. Here we have a typical example. This was a 25-year-old woman who was being worked up for infectious mononucleosis and incidentally was found to have this mass. Again, pretty classic. A large lesion in the pancreas. It's in the body tail region. It has both solid and cystic components. Within the cystic component, you can see that there is T1 hyperintensity suggesting hemorrhagic component. And the solid lesion has very minimal enhancement post-contrast. And you can see that the lesion has a thick T2 hypointense fibrous capsule around it. A slightly atypical SPN. This was a slightly older woman. She was around 52 years. And the lesion is predominantly cystic. You can see a bilobed, predominantly cystic lesion with some calcification of an internal septation. And one of the components has a thicker wall, some mural enhancing solid component. So this was found to be an SPN. I have one more case, and this is extremely unusual. This was a male patient. Age was 60 years, and this was a almost completely solid lesion, which was showing some degree of enhancement. So this turned out to be an SPN, but this is very, very unusual. The age, the gender, the size, this was barely 2.4 centimeters. So you do have a spectrum of appearances for these lesions. Moving on to mucinous cystic neoplasm. As we discussed earlier, this is typically seen in the mother age group. So you have this 30 to 60 or 40 to 60 year age group. That's where you tend to see most of these clustered together, almost exclusively in women. They're usually detected incidentally, like nearly 50% of them are asymptomatic, but sometimes they present with vague symptoms such as abdominal pain, very rarely a palpable mass. The risk of malignancy is around 4 to 17%, depending on what study you look at it, which whether it was from this decade or last decade, you'll have different numbers, but this is around a reasonable estimation, 4 to 17%. The risk of malignancy in these lesions is extremely low if the size is less than 4 centimeters and they do not have any concerning features on imaging. And these lesions that do not have malignancy, they have obviously great prognosis with 5-year survival of nearly 100%. When you do have a malignancy, again, we have to be careful about how deep is the invasive component of the malignancy. If you have invasive adenocarcinoma associated with the malignancy that's going into the underlying ovarian type stroma, they have reasonably good prognosis. But if the malignancy goes beyond the ovarian type stroma, especially if you have lymph nodal involvement, the prognosis is dismal in these patients. So yeah, one thing that I did not mention was a very characteristic histologic finding in these patients is presence of the ovarian type stroma. Okay, moving on to the imaging features. So location, almost always it's body and tail, like nearly 95% of these patients have a lesion in the body or tail. These are typically unilocular or oligocystic. So you either have like one cystic lesion or a few cystic foci, which are typically less than 2 centimeters in size each. And even when you have multiple cystic lesions, the outer contour is usually rounded without lobulations. You may see internal septations. These can be thick or thin. You may have some nodularity or thickening of the wall. Often there is no involvement of the pancreatic duct. If you do see that the pancreatic duct is dilated, then that is an indication that there may be an underlying malignancy. You may see calcifications. Typically, these are in the wall. Occasionally, you can see some calcifications along the septa too. The lesion usually has an average size of around 4.8 centimeters. This is a typical example of an MCN in a 46-year-old woman. This was instantly detected. You can see a classic appearance of the MCN. You have a single unilocular cystic lesion without any perceptible wall enhancement and without any perceptible internal septations on the CT scan. But of course, we talked about how endoscopic ultrasound is superior to CT scan in identifying internal architecture, and this patient actually had a thin internal septation. This was an MCN without any high-grade dysplasia. This patient had low-grade dysplasia, and there was no evidence for any associated malignancy. Another classic example of an MCN, this 33-year-old woman had a septated cystic lesion in the pancreatic tail. It's T2 hyperintense, T1 hypointense. You can see a thin internal septation. There was no mural nodularity. There is no thick wall, no calcifications. And at surgery, this was found to be, again, MCN with low-grade dysplasia, but no invasive cancer. Another example, here we see that there is a there's a unilocular cystic lesion in the pancreatic body with a little bit of internal complexity. You barely see some thin, faintly enhancing septations. Again, endoscopic ultrasound is superior to CT scan, so you can see that it's more complicated than what we see on CT scan. You not only have septation, but you have some nodularity along the septations. This patient also underwent resection and was found to have an MCN with no invasive carcinoma. This was again benign. This is another example of a patient who had a much larger cystic lesion in the pancreatic body tail region with a large enhancing component along the mural aspect. Again, this was, sample was found to have very high CEA level of more than 179,000. And at surgery, patient was found to have high-grade dysplasia along with microscopic foci of invasive carcinoma. And now sometimes you have atypical appearances of these MCNs too. This is one of the most atypical MCNs that I've seen. This almost looks like a serous cystadenoma. This patient was in her late 20s. That's right. She was in her late 20s, had this cystic lesion that had multiple small cystic components. It looks like there's a central scar. If you look at the outer contour, there is a lobular appearance of the outer contour. So there are a lot of things that go for a serous cystadenoma and against an MCN. But there are a few atypical things in this patient. One is her age. She was in her late 20s. The second is this was aspirated and the patient had elevated CEA level. And on surgical resection, this was found to be an MCN. There are several other entities that can look like MCN. So here we have 3 different lesions. The first is a patient who had an IPMN. You can see a lobulated, somewhat lobulated cystic lesion with calcifications along the walls and internal septations. These are, it's an oligocystic lesion. Each of these cystic lesions is more than 2 centimeters in size. So pretty good look for MCN. This is a patient who had a walled-off necrotic collection after necrotizing pancreatitis that eventually became smaller in size and developed calcifications along the wall. The location, the morphological appearance is just like an MCN, but this was a walled-off necrotic collection. This is another patient who was in her mid-30s and had this solitary cystic lesion. But the imaging appearance is just like a unilateral MCN. But on FNA, she was found to have VHL mutation in her cystic, cyst fluid analysis, which is something that points towards a serous cystadenoma. Hence, this patient did not get operated. And the last follow-up, it was stable and she's doing well. So we do see how MCNs can look like other cystic lesions, and there are other cystic lesions that can look like an MCN. So we strongly, rely on cyst fluid analysis in these atypical, situations. So cyst fluid, mucinous cystic neoplasm, they tend to have, the important features that we tend to see in these patients is one is elevated CEA, typically more than 192, low glucose level less than 50, and presence of mutations that suggest an MCN, which is KRAS. Unlike IPMN, these do not have GNAS mutations, something that is important to keep in mind. I constantly talk about mucinous versus non-mucinous lesions because non-mucinous lesions do not have malignant potential. I mean, they do not turn into malignancy. They are not pre-malignant, while mucinous lesions are pre-malignant. And that's why we always try to differentiate one from the other. Next is serous cystadenoma. This is a benign cystic neoplasm, typically seen in older age group, much more common in women than in men. Almost always these are asymptomatic, but sometimes they do grow into a pretty large size, can cause abdominal discomfort, pain. You may be able to palpate a lesion. Occasionally they can bleed into this, and that can cause some acute symptomatology too. Classic appearance. First of all, these can be located anywhere in the head, body, or tail. They have this honeycomb-like appearance to them because of numerous internal cystic components. And the separations between these cystic components tend to show a lot of enhancement. Often you tend to see a central scar that may or may not have calcification. The outer wall is typically thin, and you see a lobulated contour to the outer aspect of the lesion. And this lesion does not communicate with the pancreatic duct and almost always does not cause pancreatic ductal dilation. Again, cyst fluid analysis is something that we do for atypical lesions. In these patients, you tend to see thin, clear, non-mucinous, fluid. It's glycogen-rich. Typically tends to have low CEA and tends to have high glucose. And some people estimate the levels of the vascular endothelial growth factor. A high level suggests SCA. In our institution, we look for this molecular marker VHL, which strongly suggests a serous cystadenoma. Here we have this classic example. So you do see a honeycomb-like appearance with numerous tiny cystic foci throughout the cystic lesion, which is in the pancreatic head. Same thing that you can see on the CT scan too. And among these internal separations that show a lot of enhancement, you do see a punctate calcification. Another semi-classic appearance of serous cystadenoma. Here you see numerous cystic lesions. There are internal separations that enhance with contrast, and some of these separations have calcifications. One atypical feature is that some of these cystic lesions are quite large, more than 2 centimeters in size. So sometimes you do see cystic lesions that the serous cystadenomas that have larger cystic components. This is one atypical, a very atypical serous cystadenoma that we were not able to diagnose preoperatively. This patient had multifocal branch duct IPMNs. You can see that the main duct is not dilated, but you have multiple small cystic lesions in the pancreatic body and tail, some of which were communicating with the pancreatic duct. The assumption was that all of these are branch duct IPMNs. The largest lesion was a bilobed cystic lesion in the pancreatic body, and this was enlarging in size, and that's why the patient underwent resection. But at resection, the patient was found to have a serous cystadenoma. This was an oligocystic serous cystadenoma, which is very difficult to diagnose prospectively on imaging. This patient initially did have cyst fluid aspiration. They did not see any VHL mutation on the initial cyst fluid analysis, but the final path specimen did show some VHL mutations. Another slightly atypical serous cystadenoma. Here you can see that the lesion looks predominantly cystic in appearance on the unenhanced examination, but you do have a lot of enhancement towards the peripheral aspect. It almost looks like a centrally necrotic, solid, hyper-enhancing lesion. This would be a pretty good look for a neuroendocrine tumor. On endoscopic ultrasound, it has this spongiform appearance, echogenic appearance, which is typical for a serous cystadenoma. So Though this is not a solid lesion, it kind of looks like it's a solid lesion because you have these numerous tiny cystic lesions with brilliant enhancement of the intervening septa. So you have so many septa that are enhancing and are close to each other that it looks like a solid lesion. And next, let's move on to IPMN. Intraductal papillary mucinous neoplasm is the most common, cystic lesion. When you keep aside the pseudocysts, the most common cystic lesion, and the incidence is progressively increasing as we utilize, more and more of imaging, especially in the older age group. This is seen in the older age group. There is not a lot of gender predilection, slightly more in men, and this is a classic pre-malignant lesion that can turn into malignancy, and that's why a lot of these patients undergo serial imaging. When it comes to imaging manifestations, we have three different kinds of IPMNs. First is the branch duct IPMN, where essentially all of these IPMNs have a neoplastic ductal epithelium, and they secrete a lot of mucin that results in dilation of any component of the pancreatic ductal system that they are present in. So in the branch duct IPMNs, you have excessive mucin secretion by that particular branch duct that has the neoplastic ductal epithelium, and this becomes a cystic lesion. You can either have a unilocular cystic lesion, it could be a multiloculated lesion, may have a lot of internal complexity with septations, or it can be completely simple, just a unilocular cyst. You may have one lesion or you may have multiple, so it's either unifocal or multifocal branch duct IPMN. The average size is around 2.5 centimeters. You rarely tend to see any calcifications. These are T2 hyperintense and T1 hyperintense as expected for any cystic lesion. And depending on the internal complexity, you may see thicker septations, mural nodularity, and findings that suggest a malignancy. It's called as a main duct IPMN when it is largely limited to the main pancreatic duct. So you have this excessive mucin production within the main pancreatic duct that results in dilation of the duct. It can be either segmental or diffuse. And when you have a pancreatic duct that is dilated and the IPMN involvement goes up to the level of the ampullary region, you start seeing this interesting endoscopic appearance of what's called as a fish mouth appearance. You have a gaping opening at the major papilla with the mucin exuding through the opening. On endoscopic ultrasound, you not only tend to see the dilation, but often you tend to see some degree of irregularity along the inner wall of the dilated duct with some papillary projections. This is variable, but often you tend to see something. It's called as a mixed type IPMN when you have a component of both a branch duct component and dilation of the main duct. Typically, when this happens, you often tend to see contiguity of the dilated main duct with mucinous cystic a IPMN, a branch duct IPMN in the vicinity. Again, the main duct involvement can either be diffuse or it can be segmental. Once we have identified a lesion and characterized it as an IPMN, we need to look for any evidence of frank malignancy or high-grade dysplasia. Together, these two would be characterized as advanced neoplasia. So some of the typical findings that we look for include large size of the lesion, increasing growth of the lesion from prior exams, presence of any enhancing mural nodules, or thick nodular septations or a thick wall. Here's an example of a patient, a 66-year-old male who had moderately differentiated adenocarcinoma arising from a branch duct IPMN. You can see a lobulated cystic lesion in the pancreatic head with a lot of enhancing nodular components within the cystic lesion. And of course, we do come across some situations where we are not confident about the diagnosis, or you're worried that there may be underlying advanced neoplasia, and we go for endoscopic ultrasound-guided assessment along with cyst fluid analysis in these patients. The findings that we expect to see, it's a mucinous neoplasm, so you expect to see elevated CEA, typically more than 192. Glucose level should be low, typically less than 50. And when we are looking at molecular mutations to diagnose this lesion as an IPMN, we are mainly looking for presence of the KRAS mutation and GNAS mutation. And once you know that this is an IPMN or any mucinous cystic lesion, the next thing that you want to see is there any underlying advanced neoplasia? And the molecular mutations that correlate with such advanced neoplasia include mutations such as P53, SMAD4, PIK3CA, PTEN. There are some mutations that the pathologists look for that indicate that there is a higher likelihood of underlying high-grade dysplasia or frank invasive carcinoma. This is an example of a patient, a 69-year-old who had a branch duct IPMN. You can see a solitary cystic lesion in the pancreas, which communicates with the main pancreatic duct, but there is no dilation of the main pancreatic duct. This cystic lesion had some internal complexity. You can see that there are several septa within, and some of these septa had a nodular appearance to them, and these nodular areas actually enhanced with contrast. So obviously, there was a concern that there may be underlying, high-grade dysplasia or malignancy. The patient underwent Whipple procedure. Fortunately, this patient did not have high-grade dysplasia or malignancy. Another example of a patient with a solitary branch duct IPMN in the pancreatic tail. On a CT scan, you can nicely see this branch duct IPMN. It's a cystic lesion in the pancreatic tail, and you can see that there is an enhancing nodular component. It was measuring around 5 millimeters or so. So this was very concerning for a malignancy. But at surgery, the patient did not have either high-grade dysplasia or invasive carcinoma. Here we have another example of a main duct IPMN. This patient had dilated main duct in the region of the pancreatic body, was being surveilled. 2 years later, the diameter of the pancreatic duct significantly increased. And not only that, now we start seeing this faint higher than water retention lesion within the pancreatic duct that demonstrated minimal enhancement on contrast administration. This turned out to be a colloid carcinoma. Colloid carcinoma is a variant of adenocarcinoma that has much better prognosis than the conventional pancreatic ductal adenocarcinoma and tends to develop in these patients who have IPMN. This was another example of a patient who had an IPMN. You can see that the main duct is pretty much dilated. It was around 2.1 centimeters in caliber, and the patient had these clear-cut enhancing nodular foci within the pancreatic duct. Underwent a distal pancreatectomy and was found to have high-grade dysplasia with some small foci of invasive carcinoma. Another very interesting case of a main duct IPMN. This patient had, at presentation, diffuse marked dilation of the main pancreatic duct. You can see that the duct is dilated, but also that there is contour irregularity along the inner aspect of the duct because of all of these enhancing nodular components. In addition, this patient also had hypoenhancing metastasis. So this is a main duct IPMN with an underlying malignancy at diagnosis and also metastasis, unfortunately. Another interesting component of this IPMN is that this patient had this gastropancreatic fistula. You can see that the IPMN and its contents are contiguously extending into the lumen of the stomach. When you do have an IPMN with a fistula, you can see fistulous communication either with stomach, the bile duct, or duodenum, typically when that happens. It doesn't necessarily indicate the presence of a malignancy, but it's associated with the malignancy fairly frequently. There's a very strong association. Next, we have to talk about field effect. It's a very important thing to know. When patients come in with an IPMN and we are following them up, usually we want to see if that particular IPMN has changed for a period of time. You want to see if there is increase in size of the lesion. You want to see if there is a complexity within the lesion. There's a new malignancy that has developed. All of those things we always look for. But it's really important to remember that once you have an IPMN, irrespective of what size it is, irrespective of where it is located, the entire pancreatic ductal epithelium is at risk for developing a malignancy. So if you look at this particular patient, this patient was, I think, around 78-year-old who was initially found to have a main duct IPMN involving the distal pancreatic body and tail, who was being followed up. This was growing in size, and there was a definite concern that this patient might develop a malignancy, but he was not he was not a candidate for surgery. He had other comorbidities, including heart failure, and he was deemed not fit for surgery. So he would undergo surveillance. After around 5 years, that's when we found that the patient developed a malignancy. And at the time of the detection of malignancy, he not only had a malignancy in the pancreatic neck, away from where he had his main duct IPMN in the distal body and tail. He also had several metastatic foci in the liver, unfortunately. So the point here is that the IPMN is limited to the distal body and tail, but the malignancy developed in the pancreatic head-neck junction. So it's away from where his IPMN was. Another patient, this is the one that we have seen earlier as an example for mixed IPMN. So you have main duct IPMN, a segmental IPMN involving the pancreatic head, an adjacent branch duct IPMN in the uncinate, another branch duct IPMN in the distal body. If you look closely at the pancreatic tail, it's pretty normal. There is no IPMN involvement, either the main duct, and you don't see any side branch IPMNs around the pancreatic tail. If you look at the CT and MR on the baseline and a 3-year follow-up CT, the pancreatic tail morphology was pretty much, similar. Maybe there was some contrarregularity here 3 years later. Nothing that anybody would prospectively call as abnormality. But the patient later on developed a malignancy in the pancreatic tail. A hypoenhancing mass was seen with some regional infiltration. So this patient developed a malignancy at a site away from his known branch duct IPMNs and the main duct segment that was involved with IPMN. Again, this is an example of field defect. So once you have an IPMN anywhere in the pancreas, the whole pancreas is at risk for malignancy. So if you are looking at a patient who's coming in for follow-up, make sure that you not only look at the IPMN that they are being evaluated for, but take a look at the entire pancreas very closely every time. Next, let's move on to cystic neuroendocrine tumor. These cystic neuroendocrine tumors are almost always asymptomatic because they're usually non-functional and almost always detected incidentally on imaging. Rarely you have a functioning NAT and that they can have symptoms depending on what kind of hormones they produce. Most of these are sporadic. Occasionally, you'll come across some patients who have a familial history of neuroendocrine tumors. Typically, these are patients who have MEN1 syndrome, VHL, or some other rarer, familial entities such as neurofibromatosis. Coming to imaging features, nearly 36% of the pancreatic neuroendocrine tumors at imaging have some degree of cystic component. If you look at the resected specimen, more than half of them have some degree of cystic component. But very few of these tend to be like frankly cystic or predominantly cystic lesions. When you do see these unilocular or oligocystic lesions, that can be a diagnostic dilemma. Often, however, we tend to see that they have a pretty intensely enhancing rim. The rim often tends to be thick, a little bit nodular. The nodularity tends to be more pronounced along the inner aspect. They often tend to have some solid components. You may see calcifications, and these are slightly more common in the body tail, the cystic neuroendocrine tumors, slightly less common in the head region. And presence of any pancreatic or biliary ductal obstruction or any metastasis is usually pretty uncommon. These usually tend to be like low-grade neuroendocrine tumors. When we go for cyst fluid analysis, often they tend to have low CEA because they are not mucinous lesions. They tend to have low amylase. Again, they are not mucinous lesions. You tend to see that the glucose level is typically higher than 50. And when it comes to molecular mutations, the one that we strongly rely on to make a diagnosis based on molecular mutations is presence of the MEN1 mutation. Here's a classic example of a almost completely cystic neuroendocrine tumor. These are the ones that can be, diagnostically difficult, and they look like, MCN or a branch duct IPMN. But what you need to look for is presence of this, enhancement of the relatively thick wall, which is more than the background pancreatic parenchyma. Sometimes often it enhances more in the pancreatic phase, but you may see that the enhancement is more pronounced in the venous phase sometimes. In this patient, you can see that it looks predominantly cystic, relatively homogeneous on CT scan, but MRI, you can see the internal architecture much more clearly. This patient had a lot of debris, both dependent, fluid layering, and also in the non-dependent portion, you can see some the non-enhancing, probably necrotic component. And again, the internal complexity is much better seen on an endoscopic ultrasound exam. This was another patient with a really tiny cystic neuroendocrine tumor. This patient, you can see that there is a enhancing rim, a slightly thick enhancing rim. The enhancement is slightly more pronounced than the background parenchyma. It's more, more clearly seen on the delayed phase. This patient underwent a Dorotate PET CT scan, and Dorotate is great for these patients. It's great for surveillance, for detection of these lesions, and of course, to make a diagnosis that this is a pancreatic neuroendocrine tumor. This is another neuroendocrine tumor that was misdiagnosed as a solid pseudopapillary neoplasm. This was a young woman, around 25 years, I think. She was involved in an automobile accident, and incidentally, on the trauma workup, she was found to have this lesion. A large, the age group, as we discussed earlier, is a typical daughter age group, and you have a mixed solid cystic lesion. So good reason to believe that this could be a SPN. And that was a preoperative diagnosis, and without any further, evaluation. They did not do an FNA or a cyst fluid analysis. They directly went to surgery. which is probably not unreasonable because this would have to come out anyway, turned out to be a cystic neuroendocrine tumor. But when you retrospectively look at this, a couple of things that would be odd for SPN are one is you don't have T1 hyperintense components, hemorrhagic components within this lesion, and the solid component that this patient has shows a lot of enhancement. Most of the times, SPN, when it has solid components, the enhancement is somewhat on the minimal side, not intense enhancement, while neuroendocrine tumors tend to have much more pronounced enhancement. Next, I think I'm done with most of this, cystic lesions. Pseudocyst, I think, is best discussed as part of any talk on pancreatitis rather than as part of this. But just briefly, pseudocyst is like a loosely used term for these pancreatitis-related collections. More accurately, we should be calling them as acute peripancreatic fluid collection in the acute phase when no necrotic component is involved. This matures into a pseudocyst after 4 weeks. If you do have a necrotic component, it's a more heterogeneous collection, then you call it as acute necrotic collection, and this matures into a walled-off necrotic collection. So these pancreatitis-related collections, often, they are obviously associated with acute or chronic pancreatitis. And the thing to remember here is that they have a very variable appearance. They can occur anywhere in the pancreas. They can occur at any age. They can have any kind of appearance. They can be totally simple appearing, or they may have a lot of internal complexity. They may have calcification. So it's, very, very widely variable appearance. But background history, typically of acute or chronic pancreatitis, is very helpful in identifying these lesions. And if you do a fluid analysis, they tend to have very high amylase levels. There are a lot of other very interesting pancreatic cystic lesions. I did not talk about other pre-malignant pancreatic cystic lesions such as IOPN, which is a variant of IPMN, ITPN, and then there are several other interesting cystic lesions like lymphoepithelial cyst, ciliated foregut cyst, Asner cystic transformation. I think, in interest of time, we'll not go into details, but each of these have, some interesting characteristics to them. Finally, let's talk about management guidelines for these pancreatic cystic lesions. So pancreatic cystic lesions, as we discussed earlier, can be either malignant, they can be pre-malignant or benign. And a lot of these lesions we can, identify with certainty, but there are also several that fall in this gray zone where we are not sure what to do with them. This was a patient who had a tiny cystic lesion in the pancreatic uncinate. It was less than 1.5 centimeters in size. What do you do about this? Keep on following. She was a 60-year-old woman. Either you could follow it, she's 60, so till she becomes 80, there would be like 20 years of follow-up. There would be too much of expense, too much of, anxiety and everything, versus you resect it. And if it turns out to be like a low-grade, IPMN, then you probably overdid and resected it. And, in this particular patient, nothing was done. 7 years later, she comes back with a malignancy. This was unresectable at the time of diagnosis, and she died 5 months after this CT scan, unfortunately. This patient we have already seen before, the one who had the IPMN, main duct IPMN in the body tail, developed a malignancy away from the IPMN in the head neck region, had metastasis at diagnosis. When we diagnosed the malignancy, he already had metastasis, died within 11 months after this CT scan. So it's almost like a death sentence. These patients, when they have a malignancy, the prognosis is dismal. This is an example of another patient, a 40-year-old who had a mixed IPMN. There's segmental IPMN involved in the body tail and a branch duct IPMN in the tail. 40-year-old, what do you do? You can potentially follow this, but you'd have to follow for the next 40 years. And there's a very high likelihood that this can turn into a malignancy. So this patient underwent resection, and post-resection, she has been doing well. I think, this is totally appropriate that this patient got a resection instead of any follow-up, because we saw how these malignancies, once they develop, it's like a death sentence. And very shortly, both the patients that I showed, died. But on the other hand, you have several of these small cystic lesions that do not turn into malignancy. In fact, vast majority of the tiny pancreatic cystic lesions that we see will not turn into malignancy. So with a incidence of like approaching 40% in the general population in the elderly age group, and knowing that majority of these don't turn into malignancy. For example, this recent study from a couple of years ago was talking about how when you see cystic lesions under 2 centimeters in size, over 5 mm or more and less than 2 centimeters, they followed for like 9.2 years, and they talk about how the incidence of malignancy is 0.9 cases per 1,000 patient years of follow-up. So it's almost like there's no difference between people who do not have a small cystic lesion like this versus those that do have. But if you have all of these patients undergo imaging follow-up, that's like tons and tons of unnecessary follow-up, the expense, the anxiety, and everything that goes with it. But on the contrary, the few that do develop a malignancy, it's a virtual death sentence. So how do you balance these two is very difficult. And that's why, I think nobody knows what to do. And that's why we have so many different guidelines, and everybody has like a different way of looking at these things. So you just have to see what your referring clinicians are following and try to stick to that. One of the most widely, followed guideline is the International Evidence-Based Kyoto Guidelines, which is a revision of the revised Fukuoka guideline, which itself is a revision of Fukuoka guideline, which was a revision of Sendai criteria back in 2006. So this is what most people follow, and that's what my institution follows. This talks about presence of worrisome features or high-risk stigmata in these cystic lesions. So you're looking for size greater than 3 centimeters, enhancing mural nodules, main duct size more than 5, any abrupt change in caliber of the pancreatic duct. You're looking at a growth rate of greater than 2.5 mm per year, adenopathy, elevated CA19-9, or some clinical features like acute pancreatitis, new or exacerbated diabetes. All of these things makes it a worrisome feature. So in patients who have that, you try to see if they have recurrent acute pancreatitis, if they have multiple worrisome features, or if they're young and fit for surgery. Any of these, you try to get them to get a surgery. Otherwise, they go into the surveillance group. If patients have high-risk stigmata, which is obstructive biliary dilation, presence of a mural nodule that's enhancing and measures at least 5 millimeters in size, or the main duct is more than 10 millimeters, or they have suspicious or positive cytology on FNA. All of these, you ask them to go for a surgery unless they are not fit for surgery. And the vast majority that do not have these features, they'll undergo surveillance. Again, based on the size of the lesion, you have different recommendations as to how you should, undergo follow-up evaluation. According to the latest guidelines, they talk about stopping the surveillance after 5 years if everything is stable and they're small in size, if patient is agreeable to that. But we frankly don't know when to stop. I showed you one example of a patient who had a tiny lesion, less than 2 centimeters, that turned out to be a malignancy, unresectable malignancy 7 years later. So if that patient had undergone surveillance and stopped at 5 years, may still have developed a malignancy. So yeah, just try to follow any guideline that your referring physicians, stick to. You can use your own discretion based on what you see, the patient's clinical condition, clinical context, etc. In summary, pancreatic cystic lesions are extremely common. The imaging features and demographics can help us in making diagnosis in majority of the patients, but there are several where we are not really sure. And in these cases, the cyst fluid analysis is extremely helpful, both to make a diagnosis and to identify presence of any high-risk features for advanced neoplasia. And we have several societal, guidelines that we can adopt to see how to, follow up these patients, how to manage these patients. Yeah, that's all. I would like to acknowledge a couple of, my colleagues who provided me some cases. Thank you. That's all from me.
Thank you, Anil. That's a wonderful presentation. Made it so simple. But as you have said at the end, it's sometimes very difficult to do in a particular index case, whether to follow or whether to do surgery, especially central lesions where the surgical morbidity is pretty high. I invite Dr. Sudha Suri and other professors. There's a lot of professors in the group today. Professor Jayalata, Professor Jagan, Jyotsna, Rajgopal, so many are there. Kindly pitch in with your comments and questions to Dr. Anil. Madam, you could unmute yourself. Yeah.
Yes. Thank you. Can you hear me, sir?
Yes, ma'am. Yes, ma'am. Please go ahead.
Okay. I think this talk was excellent. So clear. The lesions have been discussed extensively. And I think the most important point here is that the speaker has tried to tell us that correlation with the other parameters like cyst analysis, like biomarkers, like molecular bio, it's very important. As it looks very easy to see that, listen to your lecture, it looks like cystic lesions are common and very easy to diagnose, but it is not true because there is a lot of overlap. And when you come to a single lesion, it becomes that a large differential diagnosis does exist. Thank you very much for a wonderful lecture. I really enjoyed the talk.
Thank you, ma'am. Thanks for your comments. Yeah, I agree. Some of these solitary cystic lesions without a clear-cut, imaging features to make a clear-cut diagnosis, it's always, diagnostic conundrum, and we, heavily rely on the cyst fluid analysis in our institution for that.
Yeah, before Professor Jagan, there's one in the chat from Dr. Gopi Srikanth, who's our gastroenterologist. He says that wonderful lecture, and one question of his is how do you differentiate chronic pancreatitis with a duct dilatation without calcification from a main duct IPMN?
Yeah, that's a great question. We do run into this problem. It's either chronic pancreatitis or it is just age-related dilation. Once the duct, long as the duct is under 5 millimeters, we never invoke main duct IPMN. Once the duct exceeds 5 millimeters, it's a problem. So one is, age-related dilation is possible. It usually tends to be smooth. You're, of course, looking for any findings of chronic pancreatitis like irregularity of the duct, strictures, and, mass, or, those other things. But when you don't have any of these things, it's smooth dilation. It becomes nearly impossible to make a confident diagnosis. What we do in our institution is try to get a sample of the fluid from the main duct. Our gastroenterologists here hesitate to stick the needle into the main duct, but what they do is they cannulate the major papilla and then take out some fluid, and we send it for analysis. If we find the mutations that we expect to see in IPMN, either KRAS or GNAS, that's when we strongly lean towards that being an IPMN. Otherwise, previously the thought was that main duct IPMN is high, has a very strong association with malignancy. Once it exceeds 1 centimeter, it's commonly, said 40%, 60% malignancy, which is probably not true. I think that data was based on the resected IPMNs that people saw in the past, like long time ago. If you look at the more recent data, there is definitely a high risk, much more than branch ducts, but it's not as high as like 40 or 60% that they talk about. So when it is under 10 millimeters, a lot of clinicians are fairly comfortable in following them up rather than going for upfront resection, especially if the patient is on the older age group. So yeah, we try to, again, go back to lean onto the cyst fluid analysis to see if it is an IPMN or not.
Thank you. Dr. Jagan, you have something to add?
Yeah, Dr. Anil, first of all, congratulations for becoming the professor. I know you are, we wish you all academic success. We know you well. I think you'll do very well. Wish you all the best. Coming to the present topic, it's a wonderful topic, and you have made it very simple. Only one simple question I have. Recently, I've come across with one of my known friend, actually, he's 74 years. He has a cystic lesion about 2 centimeters between the head and body and tail of the pancreas. And, I tried to do very carefully. There was a little bit of a bulge at the pancreatic duct, but there was no definite communication with the pancreatic duct. And there was only one internal septation, no enhancement, no mural nodule. And 6 months back also, he was evaluated same size. So they just asked him to follow up. Even I told him the same thing, but now after listening to your lecture, I just want to know your opinion on this.
If you can get endoscopic ultrasound guided sampling, I would suggest that, sir. So in our institute, they need it to be at least 1.5 centimeters in size so that they have a good chance at getting enough fluid for the molecular mutation analysis. If it is less than 1.2 centimeters, they do not go for any sampling. 2 centimeters is just about the size where you can. And if you go by the guidelines, you have to go, I think, 6 months followed by maybe a 12 or 18-month follow-up.
Yeah, so
I
after
think
6
still
months, it's the
reasonable.
same size. So we are just following
I think
again.
it is reasonable
But
to
yeah.
go for 18-month follow-up, sir.
Okay.
We don't know, like, who develops a malignancy, when that happens,
When
unfortunately,
that.
and that's why we have all of these guidelines. But just going by the statistics and the vast majority of the patients, it's reasonably safe to go for a 18-month follow-up in this situation. A thin separation is not very worrisome. If you do have thicker separation, at least 2.5 millimeters in thickness, or if you
Yeah.
have enhancing nodularity, I would, accelerate and, try to go for FNA. But if he has an option, that's always, very helpful too.
Thank you. Thank you, Anil.
Anil, there's another question in the chat box from Gopi Srikant, who's a gastroenterologist. What is the tendency to sample the cyst in your institution? Do you sample only the indeterminate lesions or most of the lesions?
Not most of the lesions. Those lesions where we don't have a confident diagnosis, those lesions that we think are mucinous cystic neoplasms, mucinous lesions, either MCN or IPMN. So if you think it's an MCN, definitely, they go ahead and do, cyst fluid analysis, FNA. If we think it's an IPMN, if we notice changes, those worrisome features, then we go for cyst fluid analysis. Otherwise, if it's, tiny lesion, not changing, we don't do anything. Like I said, they need it to be at least 1.5 centimeters in size so that they can get enough sample. So those that are less than 1.5, they don't do. Even those that are under 2, they typically don't want to. But if there is something that it makes it, challenging, either it's a younger patient, more anxious, or we see change or serial imaging, then, they go for the sampling.
One question from my side is, do you always do the molecular markers in all the cyst aspirates, or do you stop at cytology, and if necessary, do you go ahead? It's an expensive thing, I guess.
Yes, it does add expense. Actually, frankly, I'm not sure how much of insurance coverage is there, but most of the patients do undergo molecular mutation analysis. That's very helpful because cytology is not so reliable. In my slide, I mentioned, less than 1/3 have actual, enough number of cells to make a diagnosis. I think it is far less than, even 1/3. Very few patients actually, have enough cells to make a diagnosis. Most of the time, it is just based on these markers. If you just simply want to see if it's a mucinous or not, then the glucose is like really, really helpful. It's very cheap, very rapid, and all you need is a few drops. But we are talking generally, most of the times where, while we are discussing these cases in our tumor board, we have, I think, a very, very high accuracy in terms of a diagnosis before they go to surgery. But where, we want to do better is this an unnecessary surgery? We don't want to do a surgery in a patient who has an IPMN with low-grade dysplasia. That's a, unindicated surgery. Any patient who undergoes resection for an IPMN, we want it to be either high-grade dysplasia or invasive carcinoma. Then it is appropriate to, that the patient underwent surgery, unless, we are talking about like younger age group.
There's a question from Dr. Gopi again, which I think you have answered right now. Can I know the reason to sample MCNs or IPMNs if imaging is already suggestive? I think you have answered that question, yeah.
That's right, yeah. Regarding MCN, we don't know what to do again. Theoretically, if it is small in size, less than 4 centimeters, no aggressive features, the incidence of malignancy is virtually zero. It's like 0.003% or something like that. So do we follow these patients or not is something that people debate about. If it's a younger patient, I think, most would agree that it is best to resect because there is a malignant potential. But in the more elderly age group, if you detect one and if they're small and they don't have features, aggressive features, then I think it may be okay to follow them. But yeah.
Yeah, I think the real game changer, I think, has been endoscopic ultrasound, especially after MR. I think that's playing a major role, especially in aspiration of the fluid and characterization of the contents.
Yeah, I agree, sir. Definitely.
Yeah. Professor Jayalata or Jyotsna, Rajgopal, anything you want to?
Yeah, excellent presentation. Good to see Madam as well here. It's great to see her. And I just have 2 questions. Do you come across IPMNs even in the middle-aged people also? Like, what is your experience in that? And the one more thing is, what are the malignant features of a SPEN that you, I mean, have you seen any significant characteristic features in the malignant SPENs?
To answer your first question, yes, we definitely see, patients. It's a smaller subset of population, but we do see patients in their 20s and the 30s who have had IPMNs. Just, as a theoretical aside, even in kids, I think it is, I forget, some silk gene or something like that. There's some kind of gene mutation that, makes them more prone to IPMNs. Sometimes you can see that even in the younger, like pediatric age group, very uncommon. In the adult age group, yes, we do see sometimes IPMN. I've seen IOPN in this age group in the late 20s and 30s. Yes, serous hysterectomy is another thing that we talk about as a elderly age group phenomena, but we have seen younger 20s and 30s. People have that. I'm blanking on the second question. I'm sorry.
Just malignant features in SPEN.
SPEN. Okay. Yeah. Frankly, I'm not sure. We don't see a lot of these SPENs. And despite having enhancing solid components, majority of them do not have metastatic, lesions. They do not develop metastasis even on follow-up. Majority of them, a very small minority do develop. Frankly, I'm not completely sure, but I would be looking for regional infiltration, ductal dilation, etc., to see if there is any more aggressive invasive component in those patients.
Just one more question. This in IPMN, so if you have a metastasis regarding the management, does it significantly alter, or how is it? Still they go ahead and do the surgery?
No. Not for, unlike in colon cancer where you have Mets, people are very, they're very happy to go ahead and resect the Mets, do a hemilobectomy or, things like that. For pancreas, even for solitary metastasis, it's very, very uncommon to do a surgery. More recently, there is some more openness to doing that in patients who have stability over a period of time. You have a lesion in the pancreas, you have a metastasis, and you treat them for a long time. I'm not sure how much is like a long time, but if you have a stability for like 3 months, 6 months, and it's not getting worse, then, they start wondering, this is one of those patients where, the medication seems to be working, and we might give, patient chance at curative resection, and they go. But anything more than one metastasis, I've not seen anybody knowingly go for a surgery in these patients. Whether it's IPMN or not, once you have a pancreatic adenocarcinoma, people usually don't go for surgery unless, exceptional circumstances.
Thank you so much.
With Kavita around, the question always turns up is any role for PET-CT in ruling out malignancy in a pre-existing lesion? Any role for PET-CT?
It's theoretically, it can be used, but, almost always we are dealing with patients where there's a frank malignancy. You know that there is a malignancy based on, MR or CT, or you're not completely sure, and there may be like a microscopic focus of malignancy. I think if it's a microscopic focus of malignancy, small focus, then PET may not be very helpful. And depending upon the clinical context, even if there is no malignancy, I think surgeons are more inclined to resect it if there are these aggressive features in them. So yeah, practically we do not use PET-CT a lot in these cystic lesions. Of course, cystic neuroendocrine tumor is an exception, and the Garotate PET-CT has been extremely useful in these patients, and used a lot actually.
Yes, FDG PET is not very specific because the infections and inflammations all also will pick up, right? Especially in characterizing pancreatic lesions, it's not being used also.
That's right, ma'am. Yeah, just exceptions.
How do you follow these cases up post-surgery? Any role for imaging or?
Yes, sir. So it depends upon what we see in these patients. First is if it's an IPMN with malignancy, you just have to follow up just like it were any other pancreatic adenocarcinoma. If it is a IPMN and you do not have a malignancy, then you don't need any kind of follow-up to look for recurrence, because if it's a IPMN without malignancy, you do not have recurrence. But the thing is, you talk about this field effect. Once you have an IPMN, the entire pancreas is at risk for surgery, risk for malignancy. So these patients need some kind of follow-up, and we don't have a great handle as to what we should do. So they typically do undergo follow-up, but I'm not aware of any established guidelines as to how this should be done. I don't remember them now. Sorry.
As far as I understand, field effect is occurrence of malignancy elsewhere from the primary site of lesion, right?
That's correct. So the whole ductal epithelium, the entire main pancreatic duct, the branch ducts, you assume that it's all at risk for developing a malignancy once you have an IPMN. In our own internal study, we saw that once you have an IPMN involving the uncinate duct, there is much more likelihood that if you have an IPMN anywhere else in the pancreas, you're more likely to have high-grade dysplasia or malignancy. So we are even more wary about, when we see IPMNs in the uncinate duct.
Well, thank you, Anil. Any other comments or suggestions or opinions from the house? Yeah, thanks a ton, Anil, from all of us, from Crest and Hyderabad Names Group and all of us here. That's a wonderful presentation, wonderful discussion from all the delegates over here. Sir. We look forward to more of your expertise and experience sharing in the future too. Next week would be hosting another Crest webinar. This time it will be Dr. Siddharth from US. He'll be talking on imaging in epilepsy. We look forward to all of your presence and we'll be sharing the flyers soon. So with your permission, we call it a day. Good day and good night to all of you. Thanks from Crest once again.
Thank you, Anil. Have a nice weekend. Thank you very much.
Yeah, thank you, man. Thank you, sir. Yeah, it was great.